Good. Well, Anthony is recording and we're ready to go. Hello, everyone. Welcome to this webinar. I see we have hundreds of people already and people coming online all the time. So we welcome you here. As Anthony mentioned earlier, this will be recorded, so it'll be available for you to share with your friends and family at any time you wish. It'll be available on the CARP website, which is very simple to find at carp.ca. Well, I'm Bill VanGorder. I'm the Chief Education and Advocacy Officer for CARP, and I'm very happy to bring you this presentation today. We have Dr. Christine Palmay, who's a graduate from Western University, the Schulich School of Medicine, and then completed her residency at the U of T. And she currently manages a very busy family medical practice in Midtown Toronto. And for that reason, we're very lucky to have her with us today. Dr. Palmay has been listed in the Now Magazine Best of list and was honored by the Federation Medical Women of Canada with the National Reproduction Health Award. She speaks and writes regularly on topics such as immunization. And as we will see today, she has a real passion for public education. So I'm not going to take any more of her time. Dr. Palmay, over to you.
Wonderful. I just have to be given the right to share my screen, which I just have been. Okay, so a bit of a tech check. Can you hear me?
We can hear you.
And you can see my presentation?
Perfect. Yes.
We are ready to go. So welcome. Thank you so much for sharing your time with me today. I'm just delighted to speak to this group. I did a bit of browsing on the CARP website, and there's certainly a lot of advocacy happening. So I'm here to talk about immunizations, particularly RSV, respiratory syncytial virus. Say that 10 times fast. I'm going to refer to RSV from henceforth just because it is a mouthful. Main points is that this is not just a pediatric condition, which is obviously pertinent to CARP membership. These are my disclosures. I speak with pretty much any pharma company that has their hands in immunizations or women's health, the former obviously being more pertinent for today's presentation. Let's think about what's been happening in the past 5 years. I refer to COVID as the plague, that 3-year time period where we were inundated with news broadcasts suggesting that emergency rooms, hospitals were overrun. And that was the reality. And just thinking back to this past Christmas season, whether you were celebrating Christmas, Hanukkah, any other family gathering, we were delighted to invite all types of viruses to the family table as we gathered, and gathering itself perpetuates and spreads viruses such as flu, COVID, RSV. I'm going to include influenza, as well as rhinovirus and pneumococcal in that mix as well, some unwelcome guests. So what the heck is RSV? RSV is not new. RSV has existed since Kingdom Come. We just didn't have much talk about it because we didn't have any options for protection. And really, it only was a topic of conversation if a patient ended up tragically hospitalized and ended up, having to suffer from the long-term side effects of an RSV infection. So RSV is a single-stranded RNA virus, a little bit of science for those who are interested. It is seasonal. And the season coincides in Canada with every other respiratory virus, usually starting at the end of September until early April. This year, we saw actually an earlier onset of RSV. Seasons differ depending where you are in the world. Transmission is via contact with fluids from an infected person's nose or mouth, so sneezing, coughing, touching contaminated surfaces. Usually, RSV presents as annoying, mild, flu-like, cold-like symptoms that actually are quite burdensome. You can imagine when parents have to keep their children at home, a cough or a cold means something so different today than it did pre-pandemic. Symptoms can last up to 2 weeks. And in fact, some patients may actually harbor the virus and be asymptomatic, so they pass that virus along. In patients who are immunocompromised, so patients who are under 5 years young, that won't be the focus of my presentation, but children are also at risk for RSV infection, and patients over 60 due to an aging immune system. severe disease can happen, hospitalizations happen, and tragically, mortality cases, death, and long-term morbidity cases. We're going to go over some of the data. Okay, RSV is more common than we think. First of all, it's very hard, in fact, probably impossible to differentiate COVID, RSV, and influenza. I will show a brief chart trying to differentiate some symptoms, but the reality is we don't really know. And when a patient comes to my office, I kind of shrug my shoulders because we do not have testing in office for any viruses. Because we don't have routine testing, testing only happens in Canada if a patient is in the hospital. There's obviously under recognition and sometimes misdiagnosis of an RSV virus gets attributed to flu or other types of viruses. There is still the perception, very much like COVID, that RSV is just a cold. It's just a cold. It may be in some cases, and that cold may last up to 2 weeks. It may be inconvenient, but the reality is for certain patients, younger patients and older patients, severe disease can happen. And in general, we didn't really have much rhetoric about RSV. What the heck was the point of talking about it when we didn't have a means to protect ourselves? But now we do, hence all the hoopla. Looking at viruses in Canada, so this is sort of done by Surveillance Week. If you look at number 1, that marks January, and you can count backwards to about the beginning of October. We have a gamut of viruses here that, like I said, coincide with 'tis the season. It's holiday season, we're gathering, we're spreading these viruses around. Of note, during COVID, other respiratory diseases such as pneumococcal disease, influenza, RSV, they had a little bit of a siesta because we were in lockdown. Those viruses were in lockdown, and measures such as wearing masks, avoiding public places, really made some of these disease states undetectable. However, the trials for RSV actually happened during COVID. So the sheer fact that we were able to gather cases during a time when other respiratory viruses were quite quiet, in my opinion, shows the extent of the contagious nature and the burden of disease of RSV. Okay, so thinking about the two ends of the aging spectrum, patients who are hospitalized with RSV, the majority of them are patients under 5, right? Our infant patients. We do not have an immunization. This is a question I get often for younger patients. We have something called monoclonal antibodies that we give to patients who are at high risk, and that is not an immunization. It's actually providing active, impromptu antibodies to protect the infant at the time. But if you're actually looking at the morbidity and mortality, the far majority of those patients represent patients over 60, which is why there's such a war cry to ensure that we are protecting our patients most at risk, our patients over 60 years, young, not old. I always tell my patients that when they turn 60, they become an expensive vintage of wine. However, these graphs, while they're separated, and we tend to separate ages, obviously there's a fluidity in transmission. I am sure many of the listeners have lovely grandchildren. Grandchildren are lovely. When my younger patients come in and say, I'm just a young parent and I'm sick all the time. Is there something wrong with me? Since having my children, my parents, their grandparents are also sick. Is there something wrong with them? And the reality is, a colleague called his actual children little bioterrorists, unintentionally so, but those young children really do pass on infections to older patients. And when you're over 65, hugging and kissing and gathering with your grandchildren during respiratory season is obviously natural, is celebrated, but it also puts patients at risk for developing a gamut of diseases, RSV, influenza, COVID, etc. So, thinking back to my suggestion that it's nearly impossible to differentiate, some of the viruses that we're seeing lately, if you look at this chart, when patients come in the absence of testing, which I don't have in my clinic, as I mentioned, that's only done in Canada in hospitals. Hopefully that will change. Really, nobody really knows. With RSV, some patients may have a bit more wheezing, so that airy sound of your airways vibrating as you push out air. But practically speaking, there's no way to differentiate. So in my opinion, the best way to deal with this is make sure you're getting vaccinated so we're not even having the conversation. RSV is highly contagious, more so than most of the other viruses. So the incubation period from the time of exposure to the time the symptoms begin, let's call it about 4 days. The problem is that patients are often contagious before they develop symptoms, and patients who are immunocompromised, and unfortunately aging puts you in an immunocompromised state, may actually shed the virus much longer than other patients. So we're passing this virus back and forth, and 'tis the season, as I mentioned. RSV peaks during our holiday season when we are traveling and we're gathering with family and friends. The other problem with RSV is that there are two serotypes, serotype A and B. And if you get infected by one serotype, you can also 2 weeks later get infected by the other serotype. So we don't develop long-term immunity to RSV in general. And if you have one serotype, that doesn't necessarily make you immune to the other. I do not have a solution for aging. I am working on that holy grail, and I guarantee I will be, certainly not sloughing it at the office and traveling if I do discover that holy grail, that fountain of youth. But the reality is that our immune system ages with us. And there's actually a term called immunosenescence, meaning your immune system becomes weaker as we age. So this graph sort of shows the two opposite ends of the spectrum. Infants, by virtue of being young, have a young immune system that hasn't learned to react. And then older patients have an aging immune system that can't react because it's simply older. The other issue with aging is that, number one, we are additional risk factors include environmental risk factors, stress, life situations, different changes in living circumstances. So a lot of older patients live in congregate living facilities. As we age, we also gather other medical conditions such as COPD, asthma, cardiovascular disease, diabetes. These I call our frequent flyers to my clinic. And by virtue of being older, with a comorbid condition, that's a double hit to be susceptible to any disease. And then, as we age as well, because we have these extra conditions, we're also possibly on immune medications that actually further weaken our immune system. So you can see how aging itself puts patients at risk, but other independent factors associated with aging also compound that risk. They've actually studied this. They said, what is the cumulative effect of a patient with one diagnosis versus 2 versus 3? And it's compounded, meaning the more conditions that you have, the sum of those conditions actually is a higher risk than the individual components themselves. So, a patient with COPD who also has diabetes, who also has cardiovascular disease, has an immense risk of developing a severe reaction to a virus. So this is another way of looking at the data. So in terms of hospitalizations, by far, RSV is related to younger patients, or younger patients flood emergency rooms. But in terms of mortality, so looking at the patients who actually die, patients over 65, and I'm going to say over 60, represent the majority of those tragic cases. So this is another way looking at that compound data, some significant comorbidities that place patients at risk for respiratory diseases in general, but we're talking about RSV today, asthma, diabetes, coronary artery disease, anything that further weakens the immune system. And not only are these patients more at risk of developing RSV, severe RSV, and hospitalizations, but RSV itself can actually exacerbate these conditions and worsen a chronic disease for a patient. In terms of other issues relating to infection, so this is not particular to RSV. This actually pertains to influenza and shingles. I'm going to include pneumococcal and COVID as well. When we think about respiratory disease, we think about simply those respiratory conditions, that acute phase. Nobody wants that. But when I speak to patients, I say, look, we're obviously immunizing to protect that acute respiratory phase that's unpleasant, that may lead to hospitalization. But let's talk about some severe consequences of developing a virus. There is a risk of stroke. There is a risk of developing a heart attack. And then pneumonia that actually can lead to superbacterial infections that further weaken the immune system. So the risk is not just an acute situation. There are longer-term severe complications as well. Thinking about RSV in context of other diseases that we're seeing lately. So this is sort of a graph that looks at COVID versus influenza and pneumococcal disease. Look at the hospitalization rates. RSV, now Point being, we don't necessarily have good diagnostic techniques for RSV because we're not testing in the community. But the hospitalization rate is high, and we're still working on looking at stats for RSV deaths. Unfortunately, if you are hospitalized with RSV or influenza or COVID-19, most patients, if they leave the hospital, do not leave in the same condition that they entered the hospital in. So patients leave with a sense of, further exacerbation of their chronic disease. They're suffering more, they're simply sicker. They may need long-term care. So patients who are independently living, all of a sudden, when they're discharged from hospital, get discharged to a long-term care facility. That sense of loss of independence is a huge issue for my patients, and one that I spend time counseling on. Nobody wants, to leave their house. Nobody wants to go into the hospital and end up having to rely on caregivers, on family for supports. So once again, vaccines are important to prevent acute disease, obviously, but there are longer term complications that I think get lost in the message. In terms of what happens after you have an RSV infection, so this looks at high risk patients with a comorbid condition that puts them at risk versus patients who don't necessarily have a comorbid diagnosis. 6 months of intense symptoms. So if you end up in the hospital in January, in the summer, you are possibly still suffering. Once again, it's not just an acute reaction, it's not just an acute illness, longer term consequences can result. So what is the point of having this discussion? Well, we now have some options to optimally protect ourselves against RSV. Up until recently, we were just using common sense methods that weren't necessarily protective. Things like washing hands, avoiding public places when you were sick, avoiding smoking, limiting time to, exposed to younger patients or younger children, which is not necessarily possible, if you're families that are gathering, that are traveling together. Point being, until recently, the measures that we had really weren't helpful. We didn't really need to talk about it. We do have now, we have one vaccine that was approved last year at the end of August. We have a new vaccine in the market that has been approved, is not quite available. And then we have a third vaccine, Moderna, that will be released at the end of this year. I am going to speak only about the GSK vaccine, RSV, and the Pfizer vaccine, Abrifso, because Moderna hasn't actually released their data. GSK and Pfizer's vaccine have pretty much the same mechanism of action. They're a bit different in terms of what constituents are in the actual vaccine. So the GSK vaccine has something called an adjuvant, meaning they've added kind of a booster to boost the immune response. That adjuvant is not present in the Pfizer vaccine. Both vaccines address RSV A and B, so they safely protect patients from recall that I mentioned that you can get co-infected by the different strain within the same season. Relatively the same immune response. The efficacy data is generally the same as well. For all patients over 60 to protect against severe lower tract infections and super severe infections requiring hospitalization, we're having at a vaccine efficacy of about 83%. Okay, so GSK available as of last year. Most of my patients over 60 already received that vaccine. Pfizer's vaccine should be available in about a month or so. Okay, so what are guidelines saying? NACI at present is going over guidelines. We expect that they're going to release their statements within the next month. So much of what I say, is based on the availability of one vaccine and what Health Canada actually suggested. Okay. If we look at the UK was a bit quicker to come out with recommendations. They have recommendations for children for the monoclonal antibodies. Pfizer's vaccine uniquely has an indication for pregnant women so that within the 3rd trimester, they can actually pass on that immunity to their fetus. In terms of what they've recommended, they have made no preferential recommendation between the Pfizer and the GSK vaccine. And they suggest that we vaccinate all patients at risk over 60, based on a clinical decision making between the healthcare provider and the patient any time of the year. So there's a question about when you vaccinate. Do you vaccinate right before the season, throughout the year? The reality is, as I mentioned, RSV season differs according to where you are in the globe. People travel. So, RSV season in Australia happens in June. And if you travel to June, you could be exposed. ACIP, which is NACI in the United States, has come out with some guidance. Once again, they do not provide any preference for the Pfizer versus the GSK vaccine. They actually recommend vaccinating at the beginning of the RSV season. And there's some chatter whether we can co-administer this vaccine with other types of vaccines. At present in Ontario, until NACI comes out with their guidance, we are not co-administering. They're suggesting a 2-week time period between giving the RSV vaccine that is available, being the GSK option of RSV, with any other vaccine. I suspect that will change to increase efficacy. In terms of advocacy, as I mentioned, we do not have surveillance programs that are robust. I am not able to test for RSV or influenza or COVID in my office. I do not have the swabs. The swabs are only available in the hospital. So until we have data and until the community can actually participate in that, I do not think that there will be immense coverage for this vaccine. In Ontario, uniquely, and this is very unique, public health generally does not come out with any suggestions for coverage until NACI joins forces. But as we know, Ontario's long-term care facilities really suffered during COVID. So our province's response was to initially cover the GSK or RSV vaccine for patients over 60 in long-term care. At the end of December last year, they actually expanded the coverage to very specific patients, so patients who are over 60 awaiting a long-term care bed, who are in the hospital, patients on dialysis, transplant patients, patients who are homeless, and Indigenous patients. This list is forever expanding. Next week, it may include other patients. It is definitely limited. It is not what I think should be the case. But as I mentioned, in the absence of data, because of the absence of surveillance, and in the absence of NACI's recommendations, coverage will not happen anytime soon. So the question is it worth it? Many vaccines have very strange funding programs. For example, in Ontario, shingles, the shingles vaccine, which is called Shingrix, is covered for a very short window for patients between 65 and 70 with a bit of an extension because of COVID and access. It makes no sense. It doesn't actually match up with any other guidelines. NACI says that at 50, you should have the vaccine. And if you're over 18 with a comorbid condition, you should also have the vaccine. But I have a discussion with my patients who are at risk. And I say, look, there is a cost to being vaccinated. Some of my patients do not have a private healthcare plan and have to pay out of pocket, but there's also a cost to not being vaccinated. There's a cost to your health, those long-term complications, severe disease, potential loss of income, hospitalization puts patients at risk for developing other diseases. In the case of travel, we all want to travel these days. Your time traveling is sacred. Why ruin that with a vaccine preventable disease? So I think flipping the discussion and understanding, that cost is definitely an issue. These vaccines are not inexpensive, but what is the cost of developing a vaccine preventable disease? And I would venture to argue that in some cases, the cost is much higher. This document needs to be updated, but I suggest you look it up. It goes through every single publicly funded vaccine just for Ontario for our listeners. But there's some niche programs, and certainly saving some money wherever we can is of benefit these days. In terms of access, who can administer this vaccine? Why would we have consistent guidelines in Canada? They differ according to province. In Ontario, a prescription is needed from a physician, but now pharmacists can actually inject the vaccine. So I can provide a prescription to my patients and they can go to a pharmacy if it's more convenient to have the vaccine injected. In BC, pharmacists can actually prescribe and administer the vaccine. And hopefully as time shifts, there'll be more consistency in primary care providers in general, and I include nurses, nurse practitioners, pharmacists, family doctors like myself in that mix, immunizations are truly a team sport. And the reason this is evolving is that Canadians value convenient access to immunizations. We spend a lot of time thinking about anti-vaxxers. They are certainly loud, but they do not represent the majority of Canadians. Most Canadians want to and choose to be vaccinated. They just want convenience. And I think it's very exciting that we are opening access. Pharmacists, we're having campaigns in TTC stations, in schools, in community centers, etc. And Canadians, this is actual data as of last year, Canadians want expanding access. At some point, they were only able to access vaccines that were not under the public health program. We are sternly advocating now that Canadians receive any possible vaccine where they can. Point being, when a shot goes into the arm, I don't care where that is, as long as that shot is actually protecting my patient. So what should we do as a community? And I include myself in this. Be proactive. The reality is you don't know what you don't know until you know. And this was a poll that was done prior to COVID. They generally polled Canadians. It was done over the telephone. And asked the simple question, are you up to date with your vaccines? And almost 90% of the respondents said, I'm absolutely updated with my vaccines. It was worse than the opposite. 3% of patients polled were actually up to date for every vaccine they were eligible for based on their age, or risk factors, comorbidities, etc. We don't know what we don't know until we know. So education is absolutely essential. I've shared a few of my top websites I share with my patients. Engaging conversations with your primary care providers, during your annual health exam, at the start of respiratory season. I just don't focus on influenza. When I talk to my patients about influenza, I talk about pneumococcal, COVID, RSV, etc. When you're traveling, protect your travel time and plans. It's sacred right now. When you're there renewing medications for your diabetes, for your respiratory disease medications, ask your provider, what other vaccines am I eligible for based on my diagnosis? In terms of access, look at public health clinics, pharmacies, mass immunization clinics, long-term care facilities actually provide immunization clinics to some of the visitors, of their actual residents. Pediatricians will often vaccinate parents when they come in. There are school-based university programs. We have a dwindling primary care family doctor pool right now. Many Canadians, many Ontario residents do not have a family doctor, so we have to become a bit creative in accessing vaccines. These are some other great websites. They're credible. And the information is updated almost daily. I don't know if these people actually sleep. In terms of documentation, unfortunately, other than COVID, we do not have a national registry for vaccines. Some provinces, such as Alberta, have launched their own initiatives. Why this is the case, I don't know. Do I hope that this will actually open up, in terms of including other vaccines? Absolutely. But at present, the best option is to download a free app on your smartphone. We all forget our health cards. Nobody forgets their smartphones. And you can actually enter in vaccines as you receive them in different locations. It is multi-user, meaning a parent can keep track of their vaccines, their parent vaccines, and it is national coast to coast. It relies heavily on NACI. So at present, it will not provide recommendations for RSV. There are nuances with the shingles shot that NACI hasn't actually updated their guidance for. It doesn't actually catch those patients, but it's generally, a great way to engage ourselves in education. And it's one depot where you can actually keep track of your vaccines and have your primary care provider enter in a vaccine if you received it elsewhere. So thank you for your time. I think I went a bit over time, but in the spirit of Valentine's Day, I'm one time late. It's no longer what car do you drive, what do you do for work, but will you be my Valentine pending your vaccine status?
What a wonderful way to finish off, and agree. Thank you so much, Dr. Palmay. That was excellent coverage, and certainly I think gave the full understanding that we all need of RSV. I would add also at this point to your question about what we can do, what the viewers today can do, those who are watching the recording, in fact, CARP members in general. And one of the items that we can now add to your resource list, and we will put it with this recording when it is available to everybody, and that is the CARP RSV website, which is very simply found at carp.ca/RSV. So easy to remember, and there's a lot of information there about RSV, and your presentation today will also be posted there. The one other thing that's there is an opportunity for you, the viewers, to get in touch with your elected representatives in your riding, your provincial members, and ask them, tell them that you want RSV covered in your province. And you click on that link. Up will come a suggested letter that you can then change and personalize to your situation, and it will show you who your provincial member is in your riding. You click it and the email will go off to them. And we're already getting hundreds of people responding to that, and I'm sure it'll be thousands by the time we're done. So yes, there is a way. You know, I often say to our people when we're talking about getting policies like Dr. Palmay was talking about changed, and that is fine for people like the doctor and I to speak nationally on the importance of these issues, but it's really only when you as a voter talk to the person you vote for and say, I want this, that they really hear what you're saying, and that's when the message gets up to the cabinets and the health minister and the people who actually make those decisions. So we'll give you that information at the end, but I know there are a lot of questions, and Anthony has been scanning those, and he's going to come on and pass those on to you now, Dr. Palmay.
Thank you, Bill. The first two themes that I'm seeing in the questions are mostly the practical ones about the pricing and about availability. So we did see the map of where and how it can be prescribed or injected, but is it really available to those who want to pay for it? And if they do, how much are they going to be out of pocket for it?
So at present, what is available is the JSK vaccine or RSV. Pfizer has been approved. It is just not readily available in pharmacies yet. In Ontario, the price point is about $300. You know, that's actually considering the dispensing fees. It is not cheap, but we know that there is sustained efficacy. We're going to call it 2 years, probably 3. So when I talk to my patients, you know, it's about $300 upfront in Ontario. I don't know about other provinces.
It's about the same
it's sort of, you know, amortized over 3 years, we think. Certainly 2. Studies are still ongoing. Pfizer's vaccine, which is not yet available, will be in about a month or so, we're told, has the same stats. And in terms of pricing, we haven't been told yet. We also don't know whether the price of each will decrease. Competition, you know, causes competition. And the hope is that maybe the cost will decrease. Do I think that that's going to be worth waiting? No. I don't think it's going to be that immense.
And Bill, CARP's advocacy is for these vaccinations to be covered under universal pharmacare plans.
Absolutely. It's one of the 5 major vaccines that are required by all older Canadians, and all should be covered equitably for all older Canadians right across the country, no matter what province they live in. And we've
100% agree.
Yeah.
The next question, Doctor, is actually my own question. I was looking at your slideshow, and I saw an RSV-A and an RSV-B strain. Do they change over the years? Are there more expected? Does it morph like we heard about COVID changing, or is it, and the way we hear about different flu strains? Are there more than A and B?
Aren't more than A and B is an excellent question. Yeah, it is variable season to season. we don't have a vaccine that targets one more so than the other. You know, when you think about influenza, we have a lot of rhetoric about influenza A, B, the risk factors depending on age. It's not the same with RSV, and the two vaccines that we have, the Pfizer and the RSV, target both. So really it covers our basis. It also differs according to where you are in the world. So, you know, what's predominant our season here in Canada may be different in Australia, it may be different in the UK.
Question from one of our viewers, Margot. She's asking about the side effects. What do we know about side effects for the RSV vaccines?
So this is what I tell my patients verbatim, regardless of the vaccine. If you have fever, chills, flu-like symptoms up to 72 hours after receiving a vaccine, it is likely not COVID, RSV, influenza, etc. If it's beyond 72 hours, you should probably call your family doctor. In terms of the RSV vaccine, when you look at the Pfizer versus GSK data, they're quite similar. The difference with the GSK vaccine, or RSV, which is the one that was approved and available last year, is that it contains an adjuvant. It contains a booster. So you can think about it as asking, you know, when you have an internet, you have a booster signal to spread it around your house. That adjuvant is the same adjuvant that was used in Shingrix, the shingle shot. It is half the dose. And that, because we are trying to boost an immune response, these vaccines are targeting older patients when your immune system isn't as robust. You know, flu-like symptoms are more common. However, strangely, in the Pfizer trials, they do not have an adjuvanted vaccine, and they had similar rates. So really a sore arm, you have to counsel patients, you have to expect that. And in some cases, flu-like symptoms for up to 72 hours. There were no safety signals. So common questions are, you know, neurological, cardiac side effects. There were absolutely no safety signals in any of the trials.
Another question came in, and we know our members are being very active on the high-dose flu shot and in chasing their COVID vaccines, but are they getting protection from RSV with either of those two?
No, separate viruses, you know, they all gather together and they co-infect, but unfortunately, one vaccine will not give you any protective effect against the other.
And if there were monoclonal antibodies available for kids, why were they not available to seniors prior?
That is an excellent question. It's about the immune system response and how monoclonal antibodies work and how the actual RSV vaccine interacts with an older immune system. I always use the sentence that, you know, kids aren't little adults and adults aren't older kids. Immune systems behave very differently. And it's also cost effectiveness. The monoclonal antibodies are exceptionally expensive. So right now in Ontario, we have some competition that's also emerged, but monoclonal antibodies are given to high-risk patients, so young patients who are premature, who are born with congenital defects, and there's the shot that's available at present that's publicly funded is every month for about 3 months, and it's about $1,000. So it's not the most cost-effective way to deal with it. It's also not 100%. You know, the best way to look at this is primary protection. Moderna has some pediatric studies for a vaccine that have just started. We won't be seeing those for at least 5 years.
A question from Ross, and he said his doctor advised him not to get the RSV shot. So why perhaps not knowing his condition, why perhaps would he or others be advised not to get the RSV shot?
I don't know, but you should invite your family doctor to listen to this webinar then.
Okay. Bill, I'll go back to you if you have any questions while I scan for more.
Yes, well, when we're talking about protection, you were talking in your presentation about passing on the viruses to family members. In this case, we think a lot about masks in terms of COVID, but would our masks helpful, and should we think about them if we think that we might have some a virus of this kind and we need to be near our older family members?
So, you know, there's a lot of rhetoric about masks. There's a lot of confusing data that's out there. masks aren't 100% protective. I showed that one slide that up until we had vaccines, hand washing, mask wearing, avoiding public places, staying home when you're sick, those are common sense public health measures, protective somewhat against any respiratory virus. They're not fully comprehensive though. So common sense, if you are ill, if you are at risk because of a comorbid condition, if you are a young person visiting a parent or a grandparent living in a long-term care facility and you're sick, don't go. If you have to go, wash your hands and put on a mask. So yes, I actually still wear a mask in my clinic. It is not mandated by public health, but I'm seeing 40 patients a day. I would prefer to keep myself healthy so the next day I can also see 40 patients. But I'm also, protecting other patients who are coming in who are immunocompromised and potentially, exposed in my waiting room. So I think common sense prevails. I was somewhat devastated when there had to be a hand washing campaign with the onset of COVID. Hand washing is not COVID specific. It is a good idea in general. So when I think it's ridiculous now that a lot of workplaces have reverted back to having a doctor's note when you're sick. If you're sick, stay home. That's common sense. And certainly if you are exposing yourself to older patients who are extremely sick, practice as much of that public health list of measures as you can.
Thank you.
Great.
One other question before I go back to Anthony, if I might, and that is, if I'm thinking that I should get my RSV vaccine, but it is expensive, and as people have put right across the country, it's in the neighborhood of anywhere from $285 to $350, depending where you are and what your dispensing agent costs. So sometimes it's good to check around and see who has the lower dispensing fees. However, if I'm planning and it's going to cost me that amount of money, can I wait until the summer or the fall? When am I most at risk? Am I at risk right now? What's the timing that I should be thinking of if I've got to save a little money to do this?
No, excellent practical question. So as I briefly mentioned, that guidance in the UK is different than guidance in the States. So the UK at present says just vaccinate when you can. In the States, ACIP has put forward a statement saying try to vaccinate seasonally. So, in general, immunizations take about 2 weeks to be fully effective. So the idea would be, September, when RSV, the GSK vaccine, came out end of August. I had extra clinics flooded with my expensive vintage of wine patients, so patients over 60 who are lining up for the vaccine to try to get them in before the season. Practically speaking, though, people travel, seasons differ. We were expecting RSV season to be late October this year. It crept up. I'll have to wait to see what NACI says. We all have bated breath waiting to see what, I call NACI the oracle, what the oracle actually tells us. But I think, given the fact that we don't have full data yet, we're not necessarily testing in the community, which is a huge problem, not only for diagnostic purposes, but also for advocacy. How can you possibly advocate if we don't actually have numbers? Get it as soon as you can. Now, poverty is an issue, cost is an issue. So if you have to wait, getting it probably September would be ideal. I don't necessarily have my patients wait. So the other question, I'm going to ask myself my own question now. Dr. Palmay, what happens if I receive the RSV vaccine? Do I have to be revaccinated with Pfizer's? We don't know. The reality is both the Pfizer vaccine and the GSK vaccine, we definitely have robust data into year 2 and probably year 3. So thankfully, I was just on a task force and everybody was asking this question. Well, most of my patients have been vaccinated. So I'm going to wait to see what NACI says until the season after. But another question relates to what if I've had RSV? So there's 2 issues. You don't develop long-term immunity to RSV, very much like COVID, very much like influenza. You can also have RSV-A, recover, and then be out of luck and get RSV-B, 2 weeks later. So just because you've had RSV, and I'm not too sure that most people know that because most people don't end up in the hospital, But if you think you have, yes, you should still get vaccinated if you're at risk.
Okay, thank
Well,
you.
you took the questions right out of my mouth there. That was the two pressing issues.
You've been working hard. I gave you some time off.
So just to restate, and this has come in a few times, we don't know precisely how long the immunity function lasts, but the best estimate right now is we're learning, and it's 1, maybe 2 years, but we'll know
It's definitely
more.
one. It's definitely one. I'm going to say 99% sure 2, probably 3, but I'm waiting for the Oracle NACI to actually
Yes.
write that out.
And the question, is it a live vaccine?
It is not a live vaccine.
Okay. And Bill, then that sums up most of the themes in the questions. The last question that has been coming in is, can we share the slide deck that we've seen from Dr. Palmay? We are recording this, and we'll be sharing a video recording of this webinar with everyone by YouTube link. But can we get the material that people want to share this with their own doctors?
I can share the slides that are my data mining. I will have to see about the study slides. I think possibly yes, probably yes, but I will get back to you. Certainly the resource slides I will happily share.
We'll go through that, and we'll post that information on the CARP website along with this recording, so people will be able to download whatever ends up being available.
And I just wanted to add one major point that I consistently talk about when I'm presenting to not only lovely public organizations like CARP, but to my colleagues, is that we tend to, pigeonhole these vaccines and think about COVID, and then think about influenza, and then think about RSV. The reality is that if you are at risk for RSV, you are likely at risk for COVID, for influenza, for pneumococcal as well. So when I discuss vaccination, particularly during respiratory season, I sort of package it and say, this is your respiratory vaccine, Christmas, fall, Hanukkah vaccine passport. This is your armor for getting through the Canadian winter that seems to last until May, although it's been a bit different this year. And if nothing else, there were a few silver linings as a result of COVID or the plague. One of them was public engagement and understanding science. I could not use the word NACI CDC. Now, it's cocktail party chatter. I think that's immense. Education is power. But the other silver lining is learning that the best type of medicine is not treating a disease, it's preventing a disease. We were trying to vaccinate ourselves out of a pandemic. Didn't work so well initially. And it was exhausting and tragic in some cases. So I think if you flip the discussion and reframe and say, when we have the opportunity to be proactive, so much of life is not guaranteed, but in the case where we have some options, in my opinion, preventing disease is the best form of medicine.
Hey, Bill, back to you. I think we've summarized all of the questions.
Thank you again, Dr. Palmay, and I want to remind everyone that this presentation has been recorded and will be available in a number of locations, including on our website. And you can see on the screen now the carp.ca/RSV link will get you to it and more information on RSV. And if you are not a CARP member and are joining us today or watching this recording, and you would like to help us continue to provide this kind of information, please consider joining CARP, becoming a member, and helping us continue to do this kind of advocacy and make sure that messages from the experts like Dr. Palmay are available to everyone. So thank you again very much for being with us, Dr. Palmay. Thank you to all our viewers, and we look forward to seeing you at the next CARP webinar. Good afternoon, everyone.